Another paper where AI was used to depict different sort of anomalies, tumors, TB, pneumonia, or pneumothorax. And this is impressive that the performance for normal distinction was better for AI, disappointing for thoracic radiologists. But there is something very important to consider, which is that the test set only contained chest X-ray with a single anomaly, only a nodule and no more than 3 nodules. And this is not our reality. Our routine reading is not nodule and nothing else. We have nodules in patients with infiltrative lung disease, with pleural effusion, with cardiomegaly. So this is the concept of narrow AI. So these papers, they are interesting, but we need to have a critical analysis of these publications. So to summarize, AI for the detection of nodule/lung cancer on chest X-ray, the performance is comparable or superior to that of radiologists. Radiologists improve their performance with AI as second reader, but the validation of candidate lesion is still difficult. And this is, I think, a very interesting case. In this patient, there's a nodule, a peripheral nodule on the left-hand side that was due to a small cell lung cancer presenting as an apparently isolated nodule. Okay. Detected by AI, but the AI also pointed out something else in the left island. And this thing indeed corresponded on PET-CT to a malignant lymphadenopathy. And even if we go back to the chest X-ray, in retrospect, it's impossible to validate this detection. So we will have to use very performance systems, because for the detections that we cannot visually validate, we need to rely on extremely performant AI software. Second application, it's the nodule detection on CT. And another case where my residents failed to detect the nodule, but since we have this AI solution, they could detect the nodule that was close to that was a proximal nodule. And this is the case that I already mentioned, that even the best experts like me can perform detection errors, and this small lung met, I detected it at a later stage. And this is another case where the nodule could be found in retrospect at an earlier stage. So it's not a new application. The FIRCAT system were released in the 2000s. They were based on classical machine learning. And as already mentioned, CAT detection is superior to double reading, but there are some limits. Poor sensitivity for subsolid nodule detection. This is what I reported. And also a high false positive rate. But the advantage with CT is we can easily dismiss what is a false detection. But it increases the reading time. So this is the illustration that this first CAT based on classical machine learning, we need to increase the sensitivity to be able to depict this subsolid, but at a cost of many, many, many card marks. It's not manageable. And also for the segmentation, as you can see here, the algorithm failed to accurately segmentate the nodule. A part is missed, and here there's a vessel which is attached. But again, deep learning is superior to classical machine learning methods, and this is here a paper where they used CNN, and the sensitivity was 98% with only 3 false positive per CT, which is really acceptable. And I already showed you this example where it's important, and I think it is going to be a quality criterion in radiology department to use the kind of system as second readers. But there are some limits. The limits are represented by rare situation. As I said, CNN, it's an end-to-end process, but it's data hungry. They need many, many, many examples. And it's not possible to give many examples of situations which are rare. And at my hospital, we have a cohort of patients with systemic sclerosis. It's not a frequent disease, and it is associated with lung fibrosis. And as you will see, in these two examples, the AI system that we used failed to detect that there was a nodule, even if it was as big as this one, because the system has been trained to depict nodule in normal lung, none in lung of patients with systemic sclerosis. And it's exactly the same which happened with the Uber vehicle accident. I don't know if you are aware of that. It was very sad because this pedestrian, a woman, was carrying a bicycle, and the driver was not paying attention, and the car did not detect this woman as being a pedestrian, so did not stop, and it killed the woman because she was detected as an unknown object. So a pedestrian carrying a bicycle is something rare. The AI was not trained to that, like the AI system for nodule detection was not trained to depict nodule within lung fibrosis. Another application is nodule characterization. Again, two different approaches, radiomics or deep learning. Now, surprisingly, you will see that CNNs are better. In this paper based on radiomics, they're evaluating the nodule and the nodule surrounding, and they had an AUC of 0.8 for characterization, benign malignant. In this other paper, they use a CNN, and they had a better performance, not surprisingly. But again, this claim that they are going to be perfect, I don't agree for several reasons. First, this is not what we do to characterize nodules on a single CT, unless they are typical for being benign because they contain fat, or they are malignant, obviously, because they are speculated. For those which are indeterminate, we need a short-term reevaluation to depict growth, and this is a safe strategy. Quoting again this paper for Nature Medicine, where prior CT was available, the performance was equivalent to that of radiologists. Last use of AI is for prognosis. And for this, I would say that I'm not a magician, and you are not a magician, to predict the future. And it's a problem to validate some predictions. So it has been used to predict response to immunotherapy. It seems to work, but can we trust the systems? Another AI paper to predict tumor response, and again, it seems to be fantastic, but how can we use that for our routine? And also to predict survival, they had this kind of performance, which I think is not extraordinary, and I don't know how we will use that for the patient management. And lastly, again, how can we validate something that we cannot confirm, and who takes responsibility? This is a poor robot who's been used for misprediction, and the radiologist said, sorry, buddy, it comes with the job. Very briefly, we have some applications for AI, for quantification, and in my team, Guillaume Chassagnon trained an algorithm to quantify the extent of fibrosis in systemic sclerosis patients. This is where we like to use AI because it's so boring and time-consuming to compare CT examinations. And as you can see, the developed AI was very performant. There were less differences between the AI and each of the observers than between the observers themselves. AI has been used for characterization of lung fibrosis, but the results are not great because in some situations the AI does better, in other the radiologists do better. And we've been using AI for follow-up of interstitial diseases. We trained an algorithm to depict the deformation which is caused by the progression of the fibrosis, and we had 80% accuracy to predict morphological worsening and 83% to predict functional worsening. Guillaume retrained the algorithm for COVID quantification, because COVID it's ground glass, fibrosis it's ground glass, so he had a very good performance. And to conclude, to this question, does AI do better than radiologists? I think not yet. This is the proof that in this case it's obvious for everybody that there's a nodule, and this Jeffrey Hinton, one of the fathers of the deep learning, claiming that we should stop training radiologists. This is what I call a wrong prediction, even for someone who is extremely clever. But to the question that I was, is AI a true addiction in lung imaging? Definitely the answer is yes, but for results that we can reliably validate or reject, meaning nodule detection on CT, not on chest X-ray, and segmentation of ILD, but not for predictions. And we had a hype. This is the curve, with many expectations, then some disillusionment, and then we are in this phase of plateau of productivity. Thank you very much for your attention.